Hello and welcome to Meta-Evidence Articles, where we encourage community research and education with weekly articles. I'm your host, Benton Loeyball, and this week we're talking about cluster headaches. What are cluster headaches? Headaches are very common and can be described as painful, annoying, frustrating, and occasionally bad enough to warrant a day off work. Cluster headaches are a bit more extreme. They've been described as worse than labor, probably the most severe pain known, and so bad you would do anything to stop it, including shoot a nail gun into your head. So yeah, it's a bit worse than a regular headache. Cluster headaches come with an extreme amount of pain, but also come in clusters, hence the name. Untreated cluster headaches can last from around 15 minutes to 3 hours and can occur with varying frequency from every other day to multiple times a day, and can persist for weeks, months, or even years. These attacks are clock-like in their regularity, occurring at the same time every day during the cluster, with the most typical attack time being between early evening and early morning, spiking around 2 a.m. Cluster headaches are rare, affecting around 1 in every 1,000 people. Most cases start before age 30, and the majority of patients are male. Around 80 to 90% of patients have episodic cluster headaches, separated by a remission period of 3 months or longer. Chronic cluster headaches are more severe, with short or no remission periods, and up to 15% of patients with chronic cluster headaches do not respond to any current treatment. Diagnosing cluster headaches is not straightforward, as no single exam can diagnose cluster headaches. Diagnosing this condition is challenging, often requiring doctors to rule out other possible causes of headaches, and as a result, only about 1 in 5 patients are correctly diagnosed initially, and it can take an average of 5 years to receive an accurate diagnosis. Other than immense amounts of pain, cluster headaches come with a host of other not very fun symptoms. Before an attack, many patients have early symptoms called shadows for up to approximately 25 minutes, which may include pain and cognitive symptoms that indicate an attack is coming. The actual attack is characterized by being on only one side of the head, mostly the right, and is frequently restricted to a specific part of that side, such as behind the eyes. Other one-sided symptoms include tears, eye redness, stuffy nose, and sweating. Sufferers may also be unable to sit still or lie down and feel the need to jump, bounce legs, or do other activities. Short-term risks of having an attack, called triggers, include sleep disruptions, weather changes, drinking alcohol, especially beer, specific smells, and flashing lights. There are also long-term risk factors for developing cluster headaches. These include genetics, cigarette use, long-term alcohol use, and head trauma. Depression is associated with cluster headaches, but whether it causes them or results from them remains unclear. Significant complications from cluster headaches include being unable to keep a job and suicidal ideation, with over half of patients thinking or planning to take their own life. Unfortunately, researchers still don't fully understand what's happening with cluster headaches. The trigeminal nerves are the biggest nerves in the head and connect each side of the brain to the corresponding side of the face, making them a potential culprit. Another major suspect is the hypothalamus, part of the brain which contains the suprachiasmatic nucleus and is the timekeeper of the brain. Other contributors include 2 nerve pathways, the parasympathetic nervous system, also called rest and digest, and the pain network. Treatments for cluster headaches fall into 3 main categories: abortive, preventative, and neuromodulatory. Abortive therapies are used to end an underway attack and include high-flow pure oxygen, triptans, the vasoconstrictor ergotamine, which narrows blood vessels, and inhaling anesthetic lidocaine. Some patients have found relief by snorting hot sauce to end headaches, though to my knowledge, no rigorous studies have been done, and you probably shouldn't try this at home without a doctor's supervision. Preventative medications may not lower the severity of an attack, but may lessen the number of attacks. These therapies include the calcium channel blocker verapamil, lithium, anticonvulsants, and injected corticosteroids. Clinical trials have been investigating other long-term medications, including monoclonal antibodies and the hallucinogen psilocybin. Finally, neuromodulation is an emerging field for treatment and is associated with several active and completed clinical trials. These procedures attempt to physically alter the neural activity in the brain and are reserved for patients for whom other treatments have failed. Sphenopalatine ganglion stimulation and occipital nerve stimulation are invasive, reversible surgical therapies that activate facial nerves to provide relief. Deep brain stimulation is similar, but the electrode is implanted all the way down into the hypothalamus. Finally, non-invasive vagus nerve stimulation uses external devices to create an electric field powerful enough to stimulate the vagus nerve without surgery. Early clinical trials have found this to be effective for those with episodic but not chronic cluster headaches. More clinical trials are needed to find effective treatments for this rare but horrible disorder. To find clinical trials in your area, check clinicaltrials.gov. Thanks for joining us on this week's episode of MedEvidence Articles. If you'd like to know more, all of our descriptions are linked in the podcast description below. You can also visit our website at medevidence.com. MedEvidence helps answer the question of who can you trust for medical information. The MedEvidence platform provides valuable information about many medical issues and the insights of evidence-based medicine. MedEvidence educates audiences through engaging and entertaining magazines, podcasts, videos, articles, and presentations. We strive to bring together diverse voices of top-level medical professionals, researchers, and experts to provide unique and engaging content that uncovers the truth behind the data. For more great content, including discussions by physicians and subject matter experts, check out the MedEvidence podcast. My name is Benton, and we'll see you next week.